Hi, good evening, friends. So we welcome you all. We welcome you all for the sixth Procon debate organized by the Bangalore Critical Care team. And it's our honor and privilege to have Dr. Abhinav Gupta, who is a senior consultant in intensive care at Homerton University Hospital in UK. So he'll be moderating the session along with Dr. Satyajit, who will be joining very soon. Dr. Satyajit is from Western Hospital, Melbourne, Australia. And we have eminent speakers today. The moderators will be introducing Dr. Amarja, Dr. Ranajit, Dr. Deepak, and Dr. Venkatesh Gupta. And I would like to hand over to Dr. Abhinav Gupta to carry out the further proceedings.
Thank you, Dr. Jeet. At the outset, first of all, thanks very much for remembering me and inviting me. That's really an honor to be back again. I think we are having a crystalloid versus colloid first, and for the speakers, introduction of speakers, I would rather have Dr. Jeet to please introduce the speakers for the time being. Thank you.
Oh, yes. So Dr. Amarja, Dr. Amarja is she's a senior consultant. She's an associate professor in intensive care at St. John's Hospitals, Bangalore, St. John's Medical Hospital, Bangalore. And we have Dr. Ranajit Chatterjee. He's in charge of intensive care accident and emergency services at Swami Dayananda Hospital. He's a CMO and senior grade assistant SAG from by his position. And Dr. Deepak Vijayan is a senior consultant and head at the intensive care services at KIMS Hospital, Kerala Institute of Medical Science, Trivandrum, Kerala. And Dr. Venkatesh Gupta is a senior consultant in intensive care services from Manipal Hospitals, Bangalore.
Thank you, Dr. Ajit. I think should we start with the first topic, a very important one, and this one is very interesting actually. Should colloids be removed from ICU shelf? I think we can have the debate, have the verdict later on. But I think Dr. Anaja is speaking in favor of the topic of colloids, that colloids should be removed from ICU shelf. Can we start with you, Dr. Anaja, please?
Yes. Can you see my slides?
Yes.
Okay. So first of all, I would like to thank ISCCM Bangalore for giving me this opportunity, especially Dr. Ajit and Dr. Pradeep. And today we'll be discussing about the topic, that is colloids should be removed from ICU shelf. So if you look at the topic, I don't think so there is any need for the debate, as we know that colloids are already out of the shelf. I want to declare that I have no conflicts of interest. And when I look at the ICU shelf, particularly, I am not able to find any colloids. And by seeing this, I really don't think why we are having this debate today. On a closer look, I'm seeing predominantly fluids such as crystalloids, and there is absolutely no place for colloids. So fluid therapy in the ICU, so what is the choice of fluid? So if this particular question, if you ask me, irrespective of the etiology with which patients are presenting to the ICU, the fluid choice remains the same. It is the crystalloids for patients of septic shock, patients of trauma, patients with DK, patients with acute gastroenteritis. So any condition, the first and foremost, the choice of fluid is crystalloids. You think that it may be my personal opinion, but if I ask audience what is their choice of fluid, so last 5 years, based on their experience, if you look at these 3 questions, at first glance, you may think that all these questions are same. So for simplification, I will just read each question one by one. So first and foremost, have you used colloids in your clinical practice at least once in last 5 years? By asking about colloids, I am not concentrating on blood and blood products. So I don't think so any audience out of 100, if you see, maybe 1 or 2 people would have used colloids. When we go to the more specific question, have you used colloids for fluid resuscitation? Probably I may not find anybody who has used colloids for fluid resuscitation. And whether colloid was the first choice for fluid resuscitation, definitely the answer will be no. And if at all, if you have used colloids, you would not remember whether there was really any indication for using colloids. So colloids, once it was named that it is the ideal fluid for resuscitation with various characteristics such as it remains in intravascular space, it increases intravascular volume better than crystalloids, and when you resuscitate these patients, amount of fluid required will be less. But what is the clinical practice says? So in theory, if you see, theory and practice is the same, but if you clinically manage the patients, hardly you need colloids. So there is definitely mismatch between theory and practice. In order to understand why we have moved from colloids to crystalloids, there are some important physiology concepts we need to remember. So when we want to calculate total body water in 70 kg person, almost around 60% of the body weight is the total body water. And how it is distributed? It is distributed into two compartments, extracellular and intracellular fluids. In extracellular place, it is again divided into interstitial and blood plasma. After understanding this, if you look at right side, there are three types of fluids I have shown, 5% dextrose, crystalloid and colloid. So when you give 5% of dextrose, it has similar distribution like total body water. When you give crystalloid, there is a risk that it may go through the interstitial space. And if you give colloid, largely the colloid will remain in the intravascular space. So that's what the physiology says. And when you resuscitate the patient, if you want to give 1 liter of fluid, probably you need equal quantity of colloid and probably more amount of crystalloid will be required. That's what all theory says. And all this is based on this complicated formula of Starling's equation. So there are various components which are included. And by and large, if I want to summarize this equation, it is nothing but the difference between hydrostatic and amphotic pressure of capillaries and interstitium. Then why colloid is not the choice of fluid in clinical practice? And all this theory is very true, or it is very good to be true. So definitely there is something wrong. In last 1 to 2 years, you agree that type of patients you will be seeing or you would have seen are patients of COVID, ARDS with sepsis. And when you want to treat these patients, you will be skeptical. Really, I want to give fluids to these patients. And there comes the question of place of colloids when colloid is already out. My opponent will be surprised that why I am showing this slide again. The thing is, you need to remember that all this theory is applicable when the endothelium is intact. And when there is a breach in the endothelium, there is a chance that colloid is going to move into the interstitial space. So what are the conditions when endothelium is damaged? First and foremost, we need to know what is the endothelial glycocalyx. So this is a peptidoglycan, and it is consisting of various molecules such as syndecan and glypican. And it is ensuring that colloid will remain in the intravascular space. What are the conditions when endothelium is damaged? Simple intervention like giving too much fluid is going to damage endothelium. And if you look at critically ill patients, the type of patients you are seeing like ARDS, sepsis, trauma, patients of myocardial infarction, and patients of post-CPR with ischemia reperfusion injury, endothelium is already damaged. So the previous theory is what I've told. It's not at all applicable in today's world. And clinical practice says that critically ill patients have damaged endothelium and glycocalyx, and there is a risk of extravasation of colloids, and thereby it can cause harmful effects to the patients. After understanding all this theory, my opponent will be worried that there is no RCT I'm showing. So we will see what is the evidence says. This particular meta-analysis way back in 1988 already showed that colloid, especially albumin, can be harmful. And when there were conflicts of opinions or difference of opinions, there were two meta-analyses, and people were unsure, should we use albumin as a as a resuscitating fluid or not? So how we can find out the solution? When you don't know exact answer, the solution for this is do large randomized control trial and find out the answer. So here I'll be discussing about predominant RCTs, which directly compared crystalloids versus colloids, and their mortality was the primary outcome. First and foremost study, if you look at SAFE study 2004, there is a direct comparison of albumin, which is 4%, and which is compared with normal saline. So what is the utility of this study in today's world? I don't think so anybody have 4% of albumin available. What we have now is 20%. So clinical application for this study is, I really don't know. And if you look at the methodology of this study, you will be surprised that, what do you think? Ratio of colloids versus crystalloids, is it 1:3? Not at all. If you see day-wise data, it is somewhat similar, in which you can see that crystalloids are slightly, the quantity required was slightly more than colloids. Otherwise, there was no 1:3 theoretical advantage of using colloids. If you look at various subgroups when this particular fluid was given, especially patients of trauma, the concentration of fluid, if you look at, it is a 4% albumin. It is a hypooncotic solution. And when you give this solution in a patient of traumatic brain injury, it is going to cause the rise in intracranial pressure, and thereby it is going to cause harm, as it is seen by relative risk ratio of 1.36. My opponent will be interested in confusing you by showing that severe sepsis, there may be role of albumin, and you can see here 0.87, but don't look at this study. I have different study which directly compared patients of severe sepsis, and in which fluid of choice was albumin versus crystalloids. Coming to second study, which was in 2008, and this was 2x2 factorial design, in which insulin therapy and pentastarch was used for severe sepsis. This was also a negative trial, and colloids and crystalloid, the mortality was not different. When you look at the methodology of this study in detail, the recommended dose of hydroxyethyl starch was 20 ml per kg. This is a pentastarch, and the highest amount of hydroxyethyl starch you can give in a day is 20 ml per kg. But what happened in the study? Actual dose was given was 10% higher than the recommended dose. So thereby it has resulted in the harm. If you look at the SOFA score, components such as coagulation and renal abnormalities, which directly showed that hydroxyethyl starch can cause harm. And again, I've already told that crystalloid colloids ratio. Again, this study also had crystalloid colloids ratio somewhere like 1:1.3. Now, in particular, what is the harm involved when you use colloids, especially hydroxyethyl starch? So there are two graphs you can concentrate. First graph, where when you increase the dose of hydroxyethyl starch, what you can see is number of patients needing renal replacement therapy, they're increasing. Similarly, when the dose was higher, it was associated with higher mortality at 90 days. Coming to next study, that is CHEST study 2012. Here again, comparison of hydroxyethyl starch and saline. So by seeing the results of previous study, people were not convinced and they still wanted to use colloids. And this study, no doubt that again it has shown that there was no difference in mortality between the two fluids. In this particular study, if you look at what was the harm involved in hydroxyethyl starch. So secondary outcomes, if you can concentrate, there are The classification of renal outcome is based on Rifle's criteria, risk, injury, and failure. So this is one of the classification you are aware. It takes into account creatinine or urine output as a parameter to diagnose AKI. So if you look at the p-value for risk and injury, you may think that saline is harmful, but as a treating clinician, I will be concentrating on patients, how many patients actually required renal replacement therapy. And the grade or severity of renal failure was quite higher in hydroxyethyl starch. So don't get confused by seeing the p-value for risk and injury. Better concentrate on the need for renal replacement therapy. So that is quite bad, and it is going to affect patient's overall outcome, and it is one of the morbidity parameters. I'm surprised to see that why there was increased risk of AKI as per the Rifle criteria in saline and rather than in hydroxyethyl starch. So when I looked at this study in detail, in concentrating on creatinine and urine output. So if you look at day-wise, there was definitely rise in creatinine, but initially there was maintenance of urine output in hydroxyethyl starch. So what is the take-home message from this graph? Don't get confused or don't have false assurance that patients has good urine output. That means I should ignore creatinine. That is not the case, because creatinine started increasing from day 1 to day 6, and which has resulted in more number of patients requiring renal replacement therapy. So this study again showed that colloids are bad. Now, no difference in crystalloids versus colloids. Can I use colloids? You may think that if there is no difference, how does it matter if I use colloids or crystalloids? When you think that I can use colloids, you have to look at the cost. If you look at crystalloids, the cost I have mentioned here, and colloids, the cost of albumin, it is from 4,000 to 6,000. And before my opponent confuses you about use of albumin in critically ill, first and foremost, ask 2 questions to yourself. Can I resuscitate any patient with 100 ml of albumin? Answer is no, and you need more fluid. And if you want to use more and more fluid, calculate the cost as well. Finally, there was one trial which showed there was a mortality benefit with use of ringers acetate, and there was a risk involved with hydroxyethyl starch, such as need for renal replacement therapy. So hydroxyethyl starch, definitely it is a not safe colloid or fluid of choice because it is associated with higher risk of renal injury and need for renal replacement therapy. Okay, I was talking about use of albumin. I already showed you SAFE trial. Now look at this ALBAS trial. First of all, I am confused with seeing this study because in this particular study, albumin was given in order to target albumin level, serum albumin level of 3 grams. Okay, so it is like albumin is a cause or effect, and you just start giving albumin and hoping that if I maintain albumin level, patient's mortality will be less. That is totally wrong. And in Indian scenario, if you look at the amount of albumin used in this trial was 300 ml of albumin, and the cost was too high. How I can clinically apply in Indian scenario? Post hoc analysis in septic shock has shown benefit. Don't get confused by saying post hoc analysis because it has its own limitations and it should not change your clinical practice. So after discussing all these trials, the recent surviving sepsis guideline in 2021, the fluid of choice is essentially a crystalloid. And if you look at strong recommendations, crystalloids is a fluid of choice. There is no role of colloids for resuscitating the patients. In 3 scenarios, I want to ask your opinion. Maybe my opponent will explain you whether there is any role of colloids in burns. I was looking for any positive trial for burns, but I couldn't find any. And in trauma, as I already told, when you use hypo-oncotic colloids, it is going to cause harm. The people who are already using colloids in perioperative setting, be aware that even a single dose of colloid is going to cause harm. How you know that post-op, if patient develops renal failure, it can be because of the colloid which was used in intraoperative settings. And again, in summary of crystalloids and colloids, 1:3 ratio is in textbook. And when you start resuscitating the patients, actual concentration ratio of crystalloids and colloids is 1.32. So in summary, what evidence says the ratio of fluid administration was not very different among crystalloids and colloids. There was no difference in mortality as shown by these trials. One study actually showed mortality benefit with crystalloids such as 6S trial, and more adverse events with colloids, and which were very serious adverse events such as need for renal replacement therapy, and some patients had developed anaphylaxis also. So if you want to use colloids, you have to be aware about the cost, and is it cost effective? It has any cost benefit? I think colloids doesn't have any of these, and cost comes with serious side effects. So definitely I would like to choose a safer option such as crystalloids. So definitely evidence supports use of crystalloids. Thereby, I'm not telling you that crystalloids are safe, but it has side effects which are easily identified and corrected. So you need to just monitor electrolytes. And when you find that fluoride level is going up, you can adjust the IV fluids. So with this, I will end. I will be interested in knowing what my opponent has to say about colloids after listening to all this. Thank you.
Thank you, Dr. Amarja. You've presented a wonderful defense of your in defense of your topic, and you've substantiated this with ample amount of evidence from literature, from SAFE study, chest trials, 6S trials. I think it'll be very interesting to know how Dr. Ranajit Chatterjee defends his argument, right? And all to Dr. Ranajit Chatterjee. Please keep on posting your questions on the chat box, and after the debate, I think they both the panelists, both the speakers, they can take on the questions from there on, right? Dr. Ranajit Chatterjee, please.
Thank you. It's a pleasure to listen to Amarja. Can you hear me? Avinash?
Yes.
Can you hear
Yes.
me? All right. Thank you.
Yes.
Thank you. It's a pleasure to hear to Amarja. And Amarja, you are not my opponent. We are not opponents. First of all, I want to make it clear. We are basically scientists and doctors who will be keeping our minds open, and let us forget all the guidelines. Because if we follow the guidelines, let us stop the debate here. You are right that it is a crystalloid age. And I am going to defend colloids, which is the latest villain in the modern critical care. And nobody will dare to defend a villain. And though the next villain is coming, which is 0.9% sodium chloride, even the crystalloid is going to become a villain in some days to come, in some years to come. And I'll request Ajit, because as I'm not sharing my slide, to give me at least 2-3 minutes extra time. I'll try to make all of you remember these words of William Osler. I'll also conclude my studies, my lecture with the words of his words only, that medicine is a science of uncertainty and the art of probability. And obviously, should colloids be out of the ICU cells? Well, I'll say no, because I am defending colloids. And the defense is like that when Edmund Hillary was basically going upstream from Rishikesh towards Gangotri. So let me start. Amarja, you have given so much of time about albumin. I don't want to discuss albumin, because we know that when I'm speaking, thousands of liters of albumin are being used all over the ICU, all over the world. So if the debate has to stop here, because if I speak on albumin, we know about SAFE trial, we all know about Albios trials. Every trial has its own problems, and you have yourself showed it. Unfortunately, I'll say that I'll come to those about the Bicep and the 6S trials. It will be very interesting, So, so let us not discuss about albumin, because if we start discussing about albumin, we have to stop the debate here because it is being used everywhere, all over the world. So colloids cannot be put out of the cells, as albumin is there in your cells also. So let us not discuss about safe trial and albios trial. Let us go to the greater part which you have discussed. Now, let us discuss about the synthetic colloids, because it is the synthetic colloid should be put out of the ICU cells or not. This is our matter of concern. And we are basically unsure, puzzled, confused, lost, unclear, baffled. Maybe, maybe not. Because we have very clear studies like chest studies and 6 studies which are showing that colloids really cause problem. Let us see. Next slide, please. So you have already told that I'll try to confuse others. I'm not confusing. These are very well-known facts that colloids have a volume sparing effect. Theoretically, it might cross the endocalyx and go into the interstitium. But how much practically it has been shown, as Einstein told, it's right. But how much it has been shown, we don't know. But we all should agree, at least at a common point when you are debating rationally, that volume efficacy of isooncotic colloids, when compared to crystallized solutions, we need less volume. And definitely it might help in preventing positive fluid balance. It might help. And as we are in an age where we are trying to say that from day 3, 4 onwards, we want to restrict our fluids, we might think that maybe in some stage of our resuscitation, colloids might be helpful. We don't know. Next slide. So, and this positive net fluid balance is also associated with a decrease in the organ perfusion and increase in mortality. When you have an increase in positive fluid balance, we know about this. And colloids exert lower extravascular extravasation and improve tissue perfusion, especially in the initial phase of resuscitation. You have already told this. We know this. And let us not discuss about it. It may be theoretical, it may be practical. Let us leave it aside. Let us forget it. But we know for sure that if we are using colloids, especially in patients like this, where the first trial was done, next one. See this trial. This was done in British Journal of Anesthesia, where 0.9% saline was compared with hydroxyethyl starch. 130 was the molecular weight. The molecular substitution was 0.4, and it was used in severe trauma patients. And it was a randomized controlled double-blind study. And what did they find? The plasma lactate concentrations were lower over the first 4 hours than on day 1 with HES. And in the penetrating trauma group, there was better lactate clearance, less renal injury, less fluid requirement, and no mortality difference when it was compared to saline. It's a big trial that was done. It came out in BJA. Now, across the globe, that time also, the same type of trials are going on, and it came out in the American College of Surgeons, where they basically, it was an observational study done in trauma patients, and the overall mortality, again, it was significantly reduced after HES treatment compared to that of standard care. Standard care was having crystalloids as the resuscitative fluids. Now, when we go for the past trial, the European Prospective Multicenter Observational Post-Authorization Safety Study, here also, it was basically done in patients in the pediatric age group, and 1130 children up to 12 years of age group undergoing surgery was, and the comparison was done. And again, they found that the mean infused volume was around 10 ml per kg body weight, and there was no anaphylactic reactions, clotting disorders, or renal failure was observed here. So these are the patients who were in trauma, who are going on into the children group. Here, this is another study in the ovarian cancer group. These are the trials which are coming up in the later part of this, in the first half of our century. And here we find that here balanced salt crystalloids. The next one, please. Next one. Next one. That is creating a problem for me. Yes. Please move on. We have discussed about the first trial. Move on, please. Yes. Now, this is the trial that came out in the American College of Surgeons, where they found that this was a single center study. But my point of contention is that in patients of trauma, in patients, the next slide, please. In patients where their children undergoing surgery, the next slide, please. The next one. The next one, please. The next one. And in patients of ovarian cancer. Next one. Next one. In patients of colorectal surgery, where colloids was used with balanced crystalloid solutions, there was no difference in GI morbidity on day 5, no difference in postoperative complications. Crystalloid group received significantly more fluid than in the first 24 hours. These things are being found. Next slide, please. It was also used in acute pancreatitis. Again, next slide. In cardiac patients, in cardiac surgery patients, again, it was found that it doesn't cause neither increase in mortality nor increase in renal replacement therapy. Next slide. And here also, this in anesthesiology 2013, this study came out with a meta-analysis of 17 randomized studies, and they found there was no evidence of renal dysfunction was observed. So I don't want to reiterate these things. I'm just giving certain examples in trauma, in certain surgeries where colloid has been used. But next, let us come. Let the debate start from here. Bicep trial. So see, when you see the surviving sepsis guidelines, you will find 3 trials which has basically risen for the discontinuation of colloid therapy in sepsis patients. The first one is the Bicep study. Now let us see this study. A very interesting study, you know. It is a 2-pronged study where they have, on one hand, they have used the intensive insulin therapy, and on the other hand, they have used the role of crystalloids and colloids. And it is a 2x2 factorial trial. And what they have used 10% pentastarch, low molecular weight hydroxide starch, that is 200 is to 0.5. The molecular weight is quite high. We are now using 140 here, compared with ringer lactate for fluid resuscitation. And the rate of death at 28 days was seen. What was found? Next slide. Go to the last slide. HES therapy was associated with higher rates of acute renal failure and renal replacement therapy than that of ringer lactate. This was the first study which was quoted by and still quoted by surviving sepsis campaign people, that this is the reason why we are basically discontinuing colloids. The next one, next slide. Now see, the fact is known since the year 2001 that high molecular weight, poorly degradable HES preparations can present as an independent risk factor for acute kidney failure in patients with septic or septic shock. So why you are using this? The hyperoncotic colloid solution should have been employed for a brief period. Why you are using for such a prolonged period? The dose limit, you yourself said that the dose limit was exceeded. Why it was exceeded over 20 ml per kg per day, when we have already, it is known that we should not exceed that. And after doing all these mistakes, we say that colloid is harmful because it is increasing the mortality, is increasing the renal replacement therapy. And 59% of these patients already received colloids before randomization. That's the fallacy of the trials. And this was the first trial which was told that this is the trial which is why we are basically skeptical about colloid. Come to the 6S study. This is the second study. This is the Scandinavian trial. And what they have found, what they have compared tetraspan, that is hydroxyl starch 130.26%. They have given it a dose of 33 ml per kilogram of body weight. And they have found 2 things. Go to the next slide. Next slide, please. Next one. I am just going to the conclusion. Then I'll come to the details of it. They had found an increased risk of death at the date of 90. Both mortality increase and renal replacement therapy is increased. But see the fragility index of this trial. It is 2. It is not only the p-value. The fragility index of a trial is very important. That means if 2 patients is shifted from the trial, from the group which is being using hydroxyethyl starch to that which is being using ringer lactate, the trial would have shown that there is no mortality benefit, there is no mortality difference with HES, there is no mortality difference with, in renal replacement therapy. With such a small fragility index trial, this is the second one, which is telling that yes, we will not use colloids. So we are considering this trial as one of the rocks to out colloid from the clinical practice. So I don't know how much practical it is. Now let us go to the next one. This is the fragility index as told by Reynaldo Bellomo himself, that critical care clinicians should be wary of basing decisions on trials with a low fragility index. Why I'm quoting Bellomo? Because he came up with the next trial, next one, that is the chest trial. This is the final nail on the coffin of colloids, because chest trial was considered as the most important. I mean, it's just coming out from Australia, because Satyajit must be sitting here. They're really, the Australians do very good trials, and they have taken 7,000 patients, and there he have compared voluven with sodium chloride. Last time they have compared tetraspan with sodium chloride in 6s. Here voluven with sodium chloride. And what did they found? Next slide. They found, as you have already told, that there was no mortality benefit, but the renal replacement therapy was high. See, I am not confusing. It is a very straight fact that in the rifle I and rifle A, rifle R and rifle I, it is the sodium chloride which is responsible for more events of renal risk and renal injury, which is reaching statistical significance. Whereas rifle F is not reaching statistical significance with the HES, which is more in HES. It is only 0.12. Yes, you are right. The renal replacement therapy is reaching statistical significance of 0.04. Do you know why? Because renal replacement therapy was left to the clinician's choice. It is up to the clinicians to decide when to start renal replacement therapy. That means many of these patients were started renal replacement therapy in either R or I, which is not done nowadays. That means you are going into the stage 1 or stage 2 akin, or stage 1 or stage 2 of KDIGO, or stage R or I of RRT or rifle to start renal replacement therapy. That means you are starting renal replacement therapy earlier, and you are telling, oh, it needs a more of renal replacement therapy due to colloids. Very strange. Very strange. We have to go into the details of these studies and see the pragmaticity of these studies, whether these studies are right enough to decide that colloids should be kept out. Just we have to broaden our mind, use our brains and think about it. Let us go to the next slide. So yes, chest trial showed there is no difference in 90-day mortality, but definitely rise in renal replacement therapy. Next slide. Now, conveniently, the trial, the investigators, the SSC investigators, they forgot about the Christmas trial. Good trial. It was done with HES, with NaCl. Next slide. And go to the conclusion. Significantly less volume was required to achieve the previous slide, please. Previous slide, please. Previous one, please. Previous one. Please don't change if I don't say. Next slide. Significantly less volume was required to achieve hemodynamic stability for HES and NaCl in the initial phase of fluid resuscitation, and there was no adverse effect. There was no difference. The adverse effects were there, but there is no difference in the level of the adverse effects between these two groups in Christmas trial. The next trial, next slide, please. Now come the BASIS trial, and next one. This trial also compared hydroxyethyl starch with ringer lactate in severe sepsis patients. Next slide. And they didn't find no increase in acute kidney injury and ICU hospital stay. These are the two trials, and now the third trial. Next slide. I'm sorry, I can't. The previous slide, please. Yes. Now the crystal trial. Giuliani did this trial. The French trial was done. It was a big trial of around 1400 patients in each group. Here they compared the next one. They compared the colloids. They took gelatins, dextrans, hydroxyethyl starch, everything in there with crystalloids. And what are the outcomes that they find? Next slide. The next one. And the results were there. What was found that in 28 days, there was no difference in mortality, but in 90 days, the mortality was more in the crystalloid group, but than in the colloid group. Next slide, please. In 90 days, the mortality was more in the crystalloid group, and there was no difference in renal replacement therapy. Next slide. I just ask you and everybody, the 161 participants who are sitting here, why crystal trial, why Christmas trial was ignored, and why chest trial with so much of deficiencies, 6S trial with so much of deficiencies, Bicep trial which basically doesn't stand at all, has been taken into account and has been used as a diagnostic rock to remove colloid from clinical practice. Why? I ask this very pragmatic question. This is not a debate. This is a question that I'm asking. The next slide. Now we'll compare these two trials. One side you have the 6S trial and the chest trial versus the crystal trial. You see, while you are resuscitating in 6S and chest, patients had already been resuscitated when they were normotensive and arguably not in a need of to administer fluid regimes in the purpose of resuscitation. So these questions are raised on the study design itself. Similarly, monitoring. What about the monitoring? Accurate doses of colloids were not being given in these 6S and chest trials. The next slide. And the most funny part is that 52% of these patients in 6S trial had already received colloids before randomization, and 15% has received in the chest trial has already received colloids before randomization, and 59%, remember, in Bicep trial has received colloids before randomization. And we don't know whether these patients has been taken into account or not taken into account. Leave aside the renal risk, the injury part, which was more with normal saline in chest trial, and the renal failure part was more with hydroxyethyl starch, but not reaching statistical significance. Very funnily, the renal replacement therapy reaches statistical significance because it is used in Rifle R and Rifle I. I ask this question to the audience. Is this justified? Is this justified? And just see the next slide. 1788 patients of HES in Rifle R, 1912 in saline. P-value 0.007.
Sorry, Ranaji, sorry to interrupt. Can everyone hear? Because I think there's somebody posted that there's no voice. Okay.
Can you hear me?
Back again. Sorry.
Can you hear me?
Yeah, we can hear. I can hear you. I can hear you.
Okay, thank you. Thanks very much.
Okay, all right.
No problem. Another 2 minutes, please.
Yes, 2 minutes, I'm getting problem with my slides. That is the reason I'm taking a bit more time. I'm sorry for that.
Sure.
Amruja, you can get your
That's
time.
all right.
All right, that I've already explained this. See in Rifle F, you have 336 patients in HES, more than that of saline 301. The p-value is 0.12. How come the renal replacement therapy may become 0.0, reaches statistical significance? That means a lot of patients have been started renal replacement therapy at Rifle I and maybe at Rifle R. This was devastating. And this is the reason why, even after 2016, when it was decided that colloids should not be used, Giuliani comes out with this type of editorial. Is the literature inconclusive about the harm of ICS? Yes. Or Louis Vincent come out, he is not sure. So Maybaum came out with presumably correct indications and took all these studies together, and he tried to find out 6 main points which should be used while using colloids: time interval, duration of use of volume resuscitation, fluid administration algorithm, hemodynamic instability as randomization, maximum dose, and RRT. It was found that of these 6 very important points, Bicep only satisfied 2, 6S trial satisfied 1, and chest trial satisfied 2, compared to 4 to the Christmas, first trial 4, and basis trial 4. So, and ultimately, it was found that these trials were quite inadequately done when they were done thinking about using colloids. And in order to overcome these limitations, what we can do? Can you still use colloids? Because we know we are not using colloids. Can we still use colloids? So it is not what, but it is how. It is not what we do, but how we do it. Because in the end, everyone knows almost as much, just not the same way. So if you have hypovolemia, as told by Maybaum, and you can diagnose that at least one of the following criteria is that there is positive fluid responsiveness is there, lactate is high, that is signs of sepsis are there, yes. If the time interval is less than 6 hours, yes. If you can exclude that the patient is not in renal injury or in acute kidney injury, then do not cross the maximal dose of HES and use HES of those which are newer ones, that is the newer tertiary, that is those with a lower molecular weight of 130 and a lower molecular molar replacement of 0.4, and do not cross the limit of 30 ml per kg per day. You can still use colloids in your patients. That was what he told. And the last one, which I want to show you through this Cochrane library, around 30,000 patients were taken. This was in 2018. And the authors failed to find any difference between starches and whether it was starches versus crystalloids, dextrans versus crystalloids, gelatin versus crystalloids. Next slide, please. Go on changing the slides, please. Yes, next slide. See, this was basically Maybaum, who showed took all the studies together and gave points 1 to 4. Next slide. And they found, next slide, that the 6S trial, the chest trial, and the bicep trial was maintaining only 2 criteria, where the Christmas trial, the other trials were having at least satisfying 4 criteria. So I was just telling, it is not what, but how you use it. And Maybaum told us that we can use it like this. Next slide. That if you are having hypovolemia, if you are in sepsis, and if your time interval is short, and if you can exclude renal acute kidney injury in the patients, then the maximal dose of HES, if you do not exceed it more than 30 ml per kg per day, then you can jolly well use hydroxyethyl starch the first 24 hours of your resuscitation. Next slide. I'm just completing it. And this was one of the last ones done by the Cochrane library. Next one. More than 30,000 patients were taken into account. And there are a lot of studies on dextrans, gelatins, albumin, everything was taken. And what did they find? Next slide. There was no difference between starches and crystalloids in mortality. Next slides. Whether it is dextran or crystalloids. Next slide. Gelatin versus crystalloid, albumin versus or FFP versus crystalloids. Next slide. So they concluded that there was no difference in mortality, whether irrespective whether it is colloids or crystalloids. Next one. Before ending this with this slide, I just want to remind you what is the fluid, carrying fluid of colloids. They use tetraspan. The carrying fluid is a solution, a crystalloid, which has a sodium of 140 millimole per liter and chloride of 118 millimole per liter. And voluven is the carrying fluid is normal saline, that is 0.9% saline with 154 millimole per liter, and chloride is 154 millimole per liter. Basically, what you are comparing, you are basically giving crystalloids along with colloids when you are using a colloid, because the carrying fluid basically is a crystalloid, and with this amount of sodium and chloride in it. So the ideal resuscitation fluid should be one that produces a predictable and sustained increase in intravascular volume, has a chemical composition as close as possible to that of the extracellular fluid, is metabolized and completely excreted without accumulation in the tissues, does not produce adverse metabolic or systemic effects, and is cost effective in terms of improving patient outcomes. Next slide. Currently, there is no such fluid available. Unfortunate. We are unfortunate. We don't have no such fluid available for clinical use. Next one. So, my dear friends, the value of experience is not in seeing much, but seeing in wisely, as again told by William Osler. Thank you so much. I'm really sorry that I couldn't show my slides properly because it was being operated by the organizers. And thank you for your patient hearing, giving me 5 minutes extra time.
That's all right. Thank you, Ranajit. It was a wonderful talk, despite some hiccups initially with the slides. But I think both the speakers extensively dissected the trials, the Bicep trial, success trial, just trials, and both of them had their own opinions about the trials, and both of them defended. And before we move on to the questions, a bit of a rebuttal. Basically, Dr. Amarja, if you a couple of minutes, just 2 minutes to each of the speaker, and if you want to provide your opinion and answer any of the questions or in defense of whatever you say.
Are you seeing my slides?
Yes.
It's not going for slideshow. It is not. 1 minute.
We can see your slides, Bharja.
Okay. Okay. So thank you, Dr. Ranjit sir, for discussing is there any role for colloids, and you have rightly told that there is a problem with RCT. I no doubt. I don't think so that if you redo the trials, there will be some flaws in the trial, and doing one more RCT is not a cost-effective intervention. So when we know that the harm of developing renal failure was quite high, which was seen with hydroxyethyl starch, it makes me worried that when I treat the patient, really I want to choose the fluid which I'm thinking that it might cause harm, because if it does, then the need for renal replacement and the cost of requirement of dialysis is quite high. So again, I will be worried about using colloids such as the hydroxyethyl starch. Then coming to the crystal trial, what we have discussed. So when I read the conclusion that among ICU patients, as you told, 90 days mortality was lower among patients receiving colloids. It is just a observation based on this trial, and based on this, we cannot change our practice. We need further study before reaching to any conclusion about efficacy. I am quite surprised that we never discuss about problems with the crystalloids, such as the available crystalloids. If you see 0.9% saline, which has very high chloride load and which was thought to be associated with renal dysfunction or renal injury. But the current trials, if you see that, so the evidence available for the balanced crystalloids, I will take with a pinch of salt. And this was a study I thought we will discuss, because this was a study which compared balanced crystalloids versus 0.9 saline, which was negative trial. Split trial, which was done when crystalloids were compared with the balanced crystalloids, and this study never measured chloride. So when you do the study, when you know that chloride is harmful, how you can collect the parameters without measuring the chloride level for these patients? And albumin we never talked, because there may be some role of albumin, because as I discussed, the Starling's equation no longer holds true, and there is a revised Starling's concept which takes into account problem with the endothelial glycocalyx. So in that scenario, if we see that whether there is any role for albumin, but at this stage, I am really biased because as the results showed by Albias trial, when I use albumin, I am worried about the cost involved in that. And we need to be smart because SMART is the only one study which has shown benefit with use of balanced crystalloids. And that should not change our practice because the outcome was composite outcome and it was the only single center study. So if we keep on doing RCTs which are well designed, are we going to find any answer? Probably not, because as we understand that we need to assess the endothelial function, and when there is a glycocalyx which is damaged, we need to look at the markers which can be useful to know that if the endothelial is damaged, crystalloid and colloids are going to behave the same. And we need to treat the cause for this endothelial dysfunction rather than conducting RCTs with different types of fluids. Thank you.
Well, can I?
Yes.
Amraja, I will take one of your slides. Will you please show the slide of rebuttal that you have shown?
Yeah.
I actually basically didn't discuss purposefully about the crystalloids, but I like this slide very much because I was thinking of telling it to you. Sir, will you please show that slide, please, for me? The rebuttal one. That is the in which you have shown the split, the smarted, the
This
smart,
one?
and the sorted. In which you have shown the split trial, smart trial.
Yeah. 1 minute.
Yes, that one. So by the time you show me in that slide, I want to say you that, see, now we are in a era of negative trial syndromes. We are in an era of negative trial. Most of the trials which are coming were basically a big problem with us that we are being attacked by these negative trials. That is the reason why in critical care 2010, Jean-Louis Vincent is a great man. Many of you, Abhinav also might have met him. Anirban is sitting there, he might have met him. He told whether we can do a RCT in a patients of critically ill patients who are having so much of confounding factors, so much of heterogeneity, and we can pinpoint on a particular therapeutic mode, whether it is colloid, whether it is crystalloid, whether it is antibiotics, or whether it is the Marix protocol, and say, yes, this is good or this is bad. Is this possible? We are basically not debating here to counteract each other. We are basically trying to bring out our inner conscience, whether we'll do that or not. And really this slide, I didn't discuss about this slide. I just give it in this form. When the physicians are split, due to the salted menu presented by the crystalloids, there you will find those smart plus intelligent physicians who will not forget the basics. And the basics is that every patient is different. Every patient is different. Every patient has to be individualized, and guidelines can guide you. It is not a law. It is not a law. Law will change. Remember, dopamine was the drug of choice as a vasopressor in 2008. Today, nobody uses dopamine in your critical care. So by till 2008, dopamine was the only drug that was used, one of the most important drugs. In 2016, after 3-4 trials, suddenly it took the backseat. Just by p-values or by fragility index or by certain trials, which have already shown how deficient they are, we just can't decide on our clinical sense. It is ultimately the physicians has to take the decision. Maybe colloids might have to be sometimes used in your critical practice. And as I already told you, we are not discussing about the pro and con. We are discussing, otherwise it was stopped because you are using albumin every day in your ICUs. Whatever the trials say, you are using albumin. And it is not about only resuscitation fluid. It is about using colloids. So albumin is used as a colloid. So that means you should not go for a debate. So that is not the point. This is only my submission. Thank you so much.
Thank you, Ranajit. Dr. Satyajit, I think thanks for joining in, seeing him after a long time actually. So hello Satyajit. He wants to make a point as well, please.
Oh, yeah, please.
I hope you can hear me.
Yeah.
Sure. I just thought I wouldn't go into the. Thanks for both the panelists for doing a good job of dissecting the evidence. I won't go into the details of the trial literature, partly out of selfishness because I'm on holidays and really Dr. Ajit Kumar only told me yesterday, so I haven't really looked through the evidence recently on the topic. But I guess there is certainly, since we've been doing this for 25, 30 years, I remember doing colloid crystalloid controversy discussion in Sri Chitra in 1995. So this is a controversy. We are not going to close the books on it anytime soon. It is something which evokes passion on both sides. In terms of just, I'll point out a few things just to give a perspective on this, and that some of it might be of interest to you guys as a generic perspective on intensive care. So with just to start on a lighter note, if we were to tell the public that we put salt water or rice water or boiled bone broth into the human blood, they'll all be a bit taken aback, particularly in the current Indian climate. If you say a bovine bone, gelatin from the bovine bone is injected into the blood, I'm sure there will be political controversy. I'm not suggesting that that makes colloid any worse. In terms of the evidence in intensive care, I have a couple of comments. One, we have such a broad range of people, patients in intensive care, and particular relevance in this topic from trauma and bleeding or blood loss, ranging from sepsis and septic shock with the enormous amount of change in hemodynamics and capillary leakage and various things. So to think that the type of fluid we administer alone is going to make a huge mortality difference, allowing for all other part of the care, from ranging from the timing of resuscitation to early identification to treating with antibiotics and surgery and timely surgery and the whole range of things, early mobilization, sedation breaks, and all of those things. Of course, in a randomized controlled trial, you do have statistical methods to pick up effect of one of the interventions. It is likely, as Ranjit pointed out, we are likely to get negative trials when we look at a general intervention out of a whole range of interventions in a broad range of particularly ill patients. So that's one problem we face, the same in colloid versus crystalloid as well. And randomized controlled trials, while they are a highest form of evidence, they look at predominantly internal validity and the bias and unrecognized bias. So, but if you design a trial in such a way that your inclusion criteria and exclusion criteria are different and your timing of intervention is different, they don't affect the internal validity, but they affect the external validity of the trial. And so from that point of view, RCTs don't always, can also be somewhat manipulated by your trial design. I'm not saying they do it purposefully, but there is always an incentive for trialists to come up with the positive evidence, and they can choose that inclusion exclusion criteria always. Second thing is obviously, as Ranjit pointed out, all colloids are not the same, and there is some difference between various subtypes of HES. I won't go into the details. In terms of the actual trial, I do work in a center with both safe study and chest trial were done. They are reasonable studies in a way that in a real world clinical trial, there is a limit to which we can get things as perfect as possible. So always keep that in mind. In terms of So overall, my feeling is that, of course, the albumin versus the synthetic colloid part, as Dr. Amaja mentioned and both the panelists mentioned, that's also something to keep in mind. And one thing just as not really based on evidence, when someone like Gattinoni keeps on doing a trials on certain topics, you want to be careful that there is probably something in it. I remember talking about prone ventilation to Professor Gattinoni in some of the European meetings. At the time, there were no evidence, but 10 years later, once the Berlin criteria came, we had evidence. So there is probably might be something in it, particularly in certain subgroups. So always think that as Dr. mentioned, there is always a little bit of an art in medicine as well. So when you do it, how you do it, and along with what are the interventions, whether you start vasopressors early enough to reduce the volume of fluid, because the total volume of fluid is a big issue in the literature. So whether you are doing everything else right in that various centers, you're doing the trials, they are all important. So I would say overall, don't be too rigid about these things. A little bit of colloid is probably not going to hurt anyone, but don't be a zealot for colloid alone. Obviously, the cost factor is there in India as well, in the public sector, anywhere in the world. We were privileged to have a free supply of albumin by the CSL, a company in Australia. So that made a big difference in terms of availability. So that's partly why the albumin trials sort of came around. Anyway, I would leave Abhinav to make further comments. Those were just general random comments and thoughts, which are important in intensive care, I think.
Thank you, Satya. It was useful. Basically, I think the comments were really good. And before I'm slightly mindful of the time because there is a next debate that's going to happen as well, right? So before we quickly close down, thanks very much both the speakers. A couple of quick questions that we can quickly go through, basically. And any of the panelists, please. One of the questions is, what are the problems with Hemaxil? Because some centers extensively using Hemaxil. I believe the problems are same as colloid and crystalloid, right? That we've had extensive debate. Another question is plasma-lite instead of saline or ringer lactate. Amarja, would you like to quickly answer that, please?
So plasma-lite versus ringer's lactate. If you look at the recent study, Plus trial, which has shown that there is no mortality benefit. And if at all, if you are using normal saline, you have to monitor the chloride, which may be harmful because the concentration of chloride in normal saline is quite high. And if you continue to monitor the patients, it doesn't matter if you use plasma-lite or normal saline. The problem with plasma-lite or balanced crystalloids can be in case of patients of traumatic brain injury, where you would like to use normal saline because it has higher concentration of sodium, which may be beneficial in patients of TBI. So if you just monitor electrolytes, it will not make any difference if you use plasma-lite or 0.9 saline.
Right. Thank you.
I just want to comment. One comment, very small comment.
Yeah, please.
Yes.
Yeah, sure.
Yeah. See what the SSC says, 2021. We are preferring balanced salt solutions against the others. This is the guideline.
Right.
So, yeah. But the Plus trial, the latest one is saying there is no difference. The basics trial that has come out from Brazil, not much of difference, except for the SMART trial. Simple problem is that every patient has to be individualized. Normal saline, those patients which have a creatinine of more than 1.2, a chloride level of more than 110, and a pH of less than 7.2, don't use normal saline. Ringer lactate, perfectly very good, but the SID of normal saline is 0. It's such an acidotic fluid. Plasma-lite, 40 and above, such an alcoholic one. In between is the ringer lactate. Except for hepatic encephalopathy patients where lactate can't be converted into bicarbonate, ringer lactate is a very good choice. And those patients who are very much acidotic, use plasma-lite, which is alkalotic fluid. In a nutshell.
Sure, thank you. No, that's useful. So the another question that I think one of the final ones is the initial fluid of resuscitation and hypervolemic shock secondary to massive upper GI bleed. This was a question posted on the group actually. So very quickly, any of the panelists, please, they can answer.
The choice of fluid for upper GI bleed, if you ask, it is initially crystalloid, and first and foremost is to control the bleeding because that is causing the shock rather than concentrating on what type of fluid will be giving. But crystalloid is the choice of fluid, and followed by colloid. If at all, if I want to use, I will use blood as a fluid of choice.
Sure, thank you.
So in a lighter note, I just want to add that currently we follow what Dr. Amarjya is telling. We do not keep any colloids in our ICU shelf. It has been removed. There is no colloid in our ICU shelf. But all of us are aware that we have colloids in the ICU fridge, actually, the blood products, and including albumin. We do keep in the ICU fridge, not in the shelf.
That's true.
You just want to be aware that the blood and blood products are colloids, just for the audience.
Thank you. I think that has solved a lot of things, Dr. Ajit Kumar. Is that colloids are there in ICU, but you might find them.
They're in the fridge, actually, not in the shelf.
Not in the fridge, not in the shelf. But as Satyajit pointed out, that the debate has been going on for a long time actually, and I believe it's not going to end soon, and it will continue for another few years now. And I think with that, I would thank all the panelists and an excellent discussion that happened, and the people who joined in. Thank you very much, and we can move on to the next topic really. And the next one, I believe, is I'm just trying to see actually is the antiviral drugs are big fuss in COVID-19. And the people who and the person who is speaking in defense of it is Dr. Deepak V, who's consultant and head of Department of Critical Care at KIMS in Trivandrum. And against the topic would be Dr. Venkatesh Gupta, who's a senior ICU consultant at Manipal Hospitals, Bangalore. And Dr. Deepak Vijayan, you can start, please. Can you please stick to the time limit, both of you, for 20 minutes? Thank you.
Yeah, just a moment. Yeah, just a moment.
So you can open the PPT first and then click on share screen.
Is the screen visible?
Yes, please. Yeah, you can see the screen. Thank you.
Yeah.
Click on the slideshow, sir. Or on the bottom. No, not there. So in the bottom there is a book symbol, no? Next to that you click on. In the bottom next to comments. Right, bottom right. Next to comments, the fourth icon. So click on F5 to make it full screen. F5. The F5 on your keyboard. You're muted, sir. You will have to unmute.
Good evening, everyone. And thank you, the Bangalore Intensive Care Group, Dr. Ajit, Dr. Pradeep, for giving me the opportunity. I won't take much time. I would try to complete my presentation in 15 to 20 minutes. So I will be speaking on the antivirals in COVID-19, which is a big farce. Since 2 years, the world has been under siege by a global pandemic and caused by the SARS-CoV-2. Everything revolves around the COVID, and a large number of therapeutic approaches have been proposed. Except for few, like the use of steroids, there is not much robust data for support of many other modalities, including the antivirals, which always came with a hype. To quote the words of the famous statistician and management expert, Edward Geming, I couldn't find any good quality, well-designed studies with adequate power to support the use of remdesivir in COVID. To understand the treatment strategies, we should know the natural history of disease, initial viral replication phase, followed by the inflammatory response. And we all know that the mortality and morbidity in COVID is due to the inflammatory response of the body. And so whether antiviral itself is indicated should be the question. So anyway, if at all the antivirals has got a use, it should be in the initial 5 to 6 days when there is a viral replication. So the current COVID treatment strategies include the antivirals and monoclonal antibodies in the initial stages, and the immunomodulators, the steroids, interleukin-6 inhibitors like tocilizumab, baricitinib, and the prophylactic anticoagulation in the late stages. So what does the remdesivir do? Actually, it inhibits the RNA-dependent RNA polymerase and prevents synthesis of nucleic acid, thereby inhibiting the viral replication. Remdesivir and molnupiravir act almost in the same way, whereas nirmatrelvir and ritonavir, which is not currently available in India, is a protease inhibitor preventing viral replication. Remdesivir has been used around the world in large quantities, and let us first review how robust is the evidence for the remdesivir. So now let us see how the remdesivir came into usage. It was initially used in phase 1 trials of the Ebola virus in 2015. It was noted to have activity against the coronavirus family. And in March 2020, with the pandemic developing, the Gilead company requested for an orphan drug status in the USA, which means the drug production is not financially feasible, financially viable, and so the company gets incentives from the government. But this request and the approval by the FDA was largely criticized by various professional bodies, and the orphan drug status was withdrawn immediately after it was given in 2 to 3 days' time. Then in 2020, emergency use authorization was given by the FDA based on one single RCT, and then various other professional societies approved the usage, and now it is being used around the world. So now looking at the evolution of remdesivir, on 1st May 2020, European Union and the FDA gave emergency use authorization for remdesivir in patients hospitalized with severe disease. And on 20th June 2020, the Central Drug Standard Control Organization of India approved its restricted use in patients with severe COVID-19. And on 16th of October 2020, the ICMR came with a press note stating that there is not much benefit for the use of remdesivir based on the interim solidarity trial result. But almost a week later, on 23rd October 2020, FDA full authorization was given for Gilead's. And this act by FDA was largely criticized. And on 29th October 2020, the CDSCO of India advised on the continued restricted use in critically ill patients. The approval of the remdesivir by FDA baffled the scientists who were looking at various trials on remdesivir. And a report on the science came like the very, very bad look of remdesivir. The FDA held no advisory meeting on the antiviral, and the European Union signed contract without knowing of the failed trial. And in this picture is the CEO of Gilead's company and the chairman of the FDA with the President of the United States. So now let us see what the IDSA recommends on the use of remdesivir. IDSA recommendations suggest against the use of remdesivir in patients who are hospitalized and non-severe, or who are hospitalized and very severe, and in patients who are hospitalized with COVID-19 but not having an oxygen requirement. So IDSA recommends against the use of remdesivir. Now let us see what the NIH guidelines state. NIH guidelines advises against the use of remdesivir in patients discharged from inpatient setting in stable condition with no supplemental oxygen. It also recommends against the use of remdesivir in patients discharged with a requirement of supplemental oxygen, and also in patients discharged from ED who is having an increased requirement of oxygen. So now if we look at the grade of recommendations, the hospitalized and who require supplemental oxygen, the remdesivir carries a grade of B2A, and the dexamethasone plus remdesivir carries a recommendation of B2B. And when it comes to hospitalized and requires oxygen through a high flow device or NIV, the recommendation is B3. What does that mean? B means a moderate grade of recommendation, which is based on a single RCT or a subgroup analysis or an expert opinion. So to summarize, the evidence for remdesivir is very, very low. So in 2 weeks back, around on 12th January 2022, the IDSA came with a recommendation that the ambulatory patients with mild to moderate disease at high risk of progression and who have a symptom onset within 7 days, they suggested remdesivir. And this recommendation was based on a single RCT by the Pine Tree investigators in unvaccinated patients. Now, we all know a large majority of the population is vaccinated, and also a large majority of the population has been infected by COVID. The panel agreed that the certainty of evidence was low due to inaccuracy of the results. The low certainty of evidence means the true effect will be substantially different from the estimated effect. And IDSA also recommends remdesivir in severe COVID-19 patients with SpO2 of less than 94 in room air, which is a conditional recommendation based on a moderate certainty of evidence. And this evidence came from the review of 3 RCTs, which we will look at in some detail. These 3 RCTs, the outcomes assessed were mortality, time to clinical improvement, need for mechanical ventilation, and adverse events. And these RCTs, one of the important drawback was that different definitions of severity were used. So the baseline was not at all homogeneous. And also there was large bias and imprecision on the results. And also the pooled analysis failed to show a mortality benefit at 28 days. So now let us see let us review the evidence for this recommendation. Now, if we see the mortality at 29 days, they have reviewed 3 RCTs, and the risk of bias of all the 3 RCTs was quite high, and also imprecision was also very serious. However, the rate ratio was around 0.92, which suggests that there was no mortality benefit. Now, if you look at the clinical improvement, a single RCT was considered, and the rate ratio was 1.3, which show a low quality evidence for a clinical improvement. And there was a trend towards an improvement in the time to recovery, which is also based on a single RCT, which had a serious risk of bias. But the rate ratio was good, like 1.31, which carries a moderate evidence. So to conclude, these recommendations do not have a strong scientific basis. They are conditional based on moderate certainty of evidence. IDSO recommends against the routine initiation of remdesivir in patients on invasive ventilation or ECMO. And in patients with supplemental oxygen, IDSO recommends a 5-day therapy, but the panel concludes that because of bias and imprecision, the quality of evidence is very low. And the interim solidarity trial, which compared remdesivir, hydrochloroquine, lopinavir, and interferon, the various antivirals which were used, there was no mortality benefit, or there was no difference in the initiation of ventilation or duration of hospital stay. Now, the meta-analysis of 4 major trials, the Solidarity, the ACT, and 2 other trials, I agree that there is a high heterogeneity among the trials relating to 50%, but however, the results show that the stratified total risk of death was rate ratio was 0.91. And when you compare the Solidarity trial, the stratified ratio was around 0.94, and the adaptive COVID treatment trial, the stratified ratio was 0.82, which were compatible. So this means that there is no mortality difference between patients on the remdesivir group and also on the control group. Now, this is another strong study done by the group from All India Institute of Medical Science. Why I say this was a very good study is that the risk of bias of RCTs was assessed by the ROPE-2 scale, and 4 RCTs were included in their analysis with a total sample size of 7,300 patients. And among the 4 studies they have reviewed, the risk of bias was low in the WHO Solidarity trial and the trial by Wang and group, whereas high risk of bias was there in the Beagle and the Spinner studies. However, they have come out with a recommendation that the overall evidence suggested no mortality benefit with the remdesivir. And the most important part of this trial is that the cost-benefit analysis revealed higher cost with no mortality benefit. So now, when you look at the efficacy of outcome, when they have come, reviewing the mortality, they have reviewed 4 trials, and total of around 3,800 patients received remdesivir and 3,500 patients belonged to the control group. And the odds ratio was 0.92, which suggests there was no mortality benefit in the group receiving remdesivir. Another large Cochrane trial, which reviewed 5 RCTs with 7,400 patients, concluded that based on the currently available evidence, remdesivir probably has little or no effect on all-cause mortality. And they concluded that they are uncertain about the effects of remdesivir on clinical improvement and worsening. Now, the famous Discovery trial, which compared the remdesivir plus standard of care with standard of care alone for treatment of patients admitted to the hospital with COVID-19 after 7 days. There was no clinical benefit was observed from the use of remdesivir in those admitted to the hospital with COVID-19 and required oxygen. So now a new recommendation was introduced, like for non-hospitalized patients who are at high risk of clinical progression. High risk of clinical progression, they have a comorbidity like either an obesity or diabetes or an immunocompromised status. So before February 2021, it was symptomatic management and no specific therapy. Until December 23rd of 21 was monoclonal antibodies and JAK inhibitors and all. And in on December 23rd, 2021, the change in recommendations came, and that was to include remdesivir IV 3 days. And this was based on the pine tree trial, which we will look at in some detail. So the pine tree trial reviewed the use of remdesivir in early outpatient, that is less than 7 days, to prevent progression. It was a randomized double-blind placebo-controlled study, and 562 patients with symptom onset less than 7 days were included, and who had at least one risk factor for progression. And the primary endpoint was COVID-related hospitalization or death due to any cause at day 28. In the remdesivir group, the COVID-related hospitalization was around 0.7%, and in the placebo, it was 5.3%, with a hazard ratio of 0.13 and a significant p-value. And the Kaplan-Meier curve also demonstrates that. But this study had important limitations. First and foremost, the trial was designed and conducted by Gilead, which has had the right of manufacturing remdesivir. The sponsors collected the data, monitored the conduct, performed the statistical analysis, and even it was written by the writer employed by Gilead. And the study was conducted in unvaccinated patients. The study could not provide a mortality benefit. Now, when you consider the upper airway viral load from baseline to day 7, there were no difference. So the exact pathology, how the remdesivir causes a decrease in severity is not known. And the trial was conducted even before the emergence of Delta virus. Now, we have a surge due to Omicron, and we do not know how much this remdesivir is effective in patients with remdesivir, given the large number of mutations Omicron has. A new antiviral, the nirmatrelvir-ritonavir combination, was recently recommended by the IDSA panel, which suggests an initiation within 5 days of symptom onset in ambulatory mild to moderate COVID-19 patients at high risk of progression. And emergency use authorization for this drug combination, which is called Paxlovid, was given on 22nd of December. The drug is currently not available in India. So I don't think there should be much discussion on a drug which is not available in India. But for academic interest, it's not authorized for initiation of treatment in patients requiring hospitalization due to severe or critical COVID-19 patients. And the patient has to take 3 tablets twice daily for 5 days. That is 30 tablets in 5 days, which is a large number, especially in a patient who is sick with respiratory symptoms. This 30 tablets in 5 days is quite a huge number, I feel. And also, this drug has many drug interactions because of the cytochrome induction. And there is no data on pregnancy or lactation. Nirmatrelvir had antiviral activity against SARS-CoV-2 isolates belonging to the alpha, beta, gamma, delta, and lambda variants. There is no data available regarding the activity against the SARS-CoV-2 variant, even in vitro. And this recommendation came from the EPIC-HR trial, which is a randomized double-blind placebo-controlled study of nearly 2,400 patients. There are limited study details, so we do not know much about the strength of the study. So there could be potential bias factors and also selective outcome reporting. And when the study was conducted, the primary variant was Delta, and the IDSA had given a low certainty evidence for the use of Paxlovid. And again, the study was sponsored by Pfizer, which is the manufacturer of the drug. Now, let us consider this Molnupiravir, which is the new antiviral, which was recommended recently. The recommendation is that in ambulatory patients greater than 18 years with mild to moderate COVID and at high risk of progression to severe disease who have no other treatment option, the IDSA guidelines panel suggests Molnupiravir initiated within 5 days of symptom onset rather than no Molnupiravir. And there is an important remark also on this, that is patients who put a higher value on putative mutagenesis and other adverse events or reproductive concerns and lower value on the uncertain benefits would reasonably decline Molnupiravir. I think that statement itself tells us whether Molnupiravir is effective or not. The panel agreed that the overall certainty evidence was very low, and given the concerns of the inaccuracy of the results, and when the potential concerns of viral mutagenesis and in immunocompromised persons and safety in persons of the reproductive age. So it is like those who are taking molnupiravir should use contraceptive for at least up to 3 months, and more data needed on the potential adverse effects. The recommendation of molnupiravir come from the Move Out trial. Actually, it's a phase 3 double-blind placebo-controlled trial, and around 1,433 patients were randomized within those who are within less than 5 days of symptom onset and at least one risk factor for progression. Again, you have to take 2 tablets a day for 5 days. The primary endpoint was incidence of death or hospitalization at day 29. The interim analysis showed an absolute difference of 6.8, which was significant. But when the final analysis came, the absolute difference came down to 3%, and this significance value is not mentioned in the study, and this could be an underpowered study also. And also, one important factor is that the subgroup analysis does not show a benefit with the previous patient who had a previous SARS coronavirus infection or who has got a baseline lower viral load, and in diabetic patients. Actually, diabetic patients are those groups who require some sort of antivirals. And the study was conducted in unvaccinated patients. So how it behaves in vaccinated patients, we do not know. To summarize, search for an effective therapy against COVID is the need of the hour. None of the antivirals which came out till now are silver bullets. There is only a limited role for antivirals in COVID-19 and need RCTs to prove its efficiency. Most of the antivirals came with a big hype, and most of it has gone awry. Thank you.
Thank you very much, Dr. Deepak. It was your points were excellently supported by a range of evidence that you provided. It will be interesting to see what the next speaker has to say, and inviting Dr. Venkatesh basically to talk on.
Not audible, sir. You're not audible.
Oh, sorry. Can you hear me now, Dr. Deepak?
Yes,
Thank
yes.
you. Thank you for your.
Most
points.
others can hear you, so it might be.
Okay, thank you. Yeah, thank you, Dr. Satya. So inviting Dr. Venkatesh basically for supporting, for going against this topic actually, so that antiviral drugs are big for us in COVID-19, and Dr. Venkatesh.
Sorry, I cannot hear you. I cannot hear the panelist and moderator.
Am I audible to other people?
Yeah, I can hear. I can hear.
Oh, thank you.
We all
Thank you.
can hear.
Thank you. I'll just chat right in the chat box for Dr. Deepak. Thank you. Dr. Venkatesh, can you please start now?
Good evening, everyone. First of all, I would like to thank Bangalore Intensive Care Chapter, Dr. Pradeep, to give me this opportunity. I wish Dr. Deepak is also able to listen to my talk. Can we do something about that?
So, Dr. Deepak, are you able to hear? Dr. Deepak.
In the meanwhile, I'll share my screen.
Yeah.
Is
Dr. Deepak can unmute and speak.
Is my screen visible?
Yes, yes, sir.
Yes, please. Your screen is visible.
So Dr. Deepak has just logged out. He's just going to log in again. Yeah.
I think we'll update Dr. Deepak. Can you?
Yeah.
If you can start if you want.
Yeah,
Yes.
yeah.
Yes. Yeah.
Thank you. So, Dr. Deepak, my opponent, has already set the stage with a lot of evidence how the antivirals are not of big use or big farce. But let me go through some amount of evidence where antivirals are still a hope in this situation of pandemic. So as he also mentioned, we understand the pathogenesis in two main processes. Early in the clinical course, it is dominated by replication of the SARS-CoV-2 virus, and subsequently it is always dysregulated immune or inflammatory host response. So our attempt is to prevent this stage of progression into the third stage of hyperimmune stage, and try to see whether we can control the infection early in the viral response phase. That is where our antivirals are essentially going to be helpful. And we are all very well aware that remdesivir has been approved by FDA in December 2020, and the latest agents molnupiravir and nirmatrelvir in December 2021. I'm going to take you in the reverse direction of what Dr. Deepak has presented. I'm going to take you through molnupiravir and then end up with remdesivir. So this process, this viral life cycle helps us understand how the antivirals are going to act. What I'm interested here is once the virus gets uncoated, the RNA translates into polypeptides, and these polypeptides, with the help of 3-chymotrypsin-like protease, undergoes proteolysis into non-structural proteins, and that is where the drug nirmatrelvir, protease inhibitor, is going to act and stop this process so that further replication of the virus halts. Whereas the rest of the two drugs, molnupiravir and remdesivir, are going to inhibit RNA-dependent RNA polymerase. So the molnupiravir, he has also discussed about the mechanism of action. So I'll directly go to the studies. After establishing the dosage in the phase 1 study, the phase 2 study established the safety, tolerability, and antiviral effect of molnupiravir. So this is interesting to see that this study concluded that the direct acting antiviral shown to be highly effective at reducing nasopharyngeal SARS-CoV-2 infectious virus. It's not just virus, infectious virus and viral RNA, and has favorable safety and tolerability profile. So this is the first clinical trial to demonstrate the ability of treatment to reduce and eliminate infectious SARS-CoV-2 virus. This is in little bit of contradiction to the remdesivir study, where there was no significant difference in the viruses that were shown at the end of the therapy from the nasopharynx. So then the molnupiravir went through several phase 3 trials. One of the probably we can look forward is the Move Ahead trial, that is the study of molnupiravir for prevention of coronavirus disease in adults who resided with a person infected with COVID-19, and see whether the disease can be prevented at day 14. This is still in the initial stages of the study, but I feel that this probably can come in handy as post-exposure prophylaxis. So the most talked about study Dr. Deepak also has mentioned is molnupiravir for oral treatment of COVID-19 in non-hospitalized patient. As he already mentioned, it is done in a non-hospitalized unvaccinated adults, at least one risk factor for severe COVID-19 illness. So the interim analysis at 50% enrollment showed a relative risk reduction of 50% of the risk of hospitalization for any cause or death through day 29 in the molnupiravir group compared to the placebo. However, when all participants were analyzed, the relative risk reduction got reduced to 30%. However, that is not that did not take away the credibility of the statistical significance. So how it happened, difficult to explain probably, but the death and adverse events were not significant, and the study concluded that early treatment with molnupiravir reduced the risk of hospitalization or death in at-risk unvaccinated adults with COVID-19. So to look at certain points in the study, the evidence for molnupiravir is better than most of other COVID-19 therapies. We know there are the n number of medications that came in, and compared to that, probably this is the outcome is slightly better. The benefit is small but potentially important during this pandemic, and this is a single study with borderline results. Probably any replication of similar result is required, and probably we hope for further studies in the coming days. As he also mentioned about the mutagenesis, there is a theoretical risk that when the drug gets metabolized by the human host cell, it can get incorporated into the host DNA, leading to mutations. So this has been again studied in two in vivo rodent mutagenicity assays. One was equivocal, but the other study showed no evidence of such mutagenicity. So based on that, FDA has clearly said with the available genotoxicity data and just the 5-day duration of the treatment, probably molnupiravir has very low risk of genotoxicity. Of course, there are concerns about potential effects of molnupiravir on SARS-CoV mutation itself, but those things need to be further observed and studied. So what is the status of molnupiravir in India? The DCGI, the Drugs Controller General of India, has already given emergency use authorization to manufacture and market oral antiviral drug molnupiravir capsules. So probably this is not incorporated in any of the Indian guidelines set, but I'm not surprised in the coming days if it gets incorporated. So coming to the next important drug is Paxlovid, that is ritonavir boosted nirmatrelvir. The mechanism of action we have already discussed. Again, as Dr. Deepak said, this is the EPIC HR study, and there is one more EPIC SR study. These are all phase 2 and 3 trials. HR is the high-risk population where they looked at unvaccinated high-risk participants with at least one risk factor for progression to severe disease. And they looked at 2,446 individuals with confirmed COVID-19. So the drug significantly reduced the risk of hospitalization or death by 88% when administered within 5 days. That was quite significant statistically, and that went up to 89% when administered within 3 days of the symptom onset. Because of the overwhelming efficacy results, the study was stopped by DSMB. And this is the EPIC SR study. This is the standard risk. So they included patients here with low risk of progression to severe disease, or here they also looked at vaccinated adults with at least one risk factor for progression to severe disease. It showed an interim analysis of a marked 70% reduction in the hospitalization, which is significant considering the way our pandemic has progressed. And one of the novel primary endpoint, what they looked at is the self-reported sustained alleviation of all the symptoms for 4 consecutive days, but that was not met. There are definitely certain dosing and safety concerns. Here, what happens, because the ritonavir, which increases the efficacy of nirmatrelvir by inhibition of the cytochrome P450, we should always be very cautious when we are prescribing this medication in patients who are already on medications which can get affected by or dependent on the metabolism by P450. And the efficacy is comparable to the efficacies reported for sotrovimab, that is the novel monoclonal antibody, which is supposed to be effective against Omicron, that is 80% relative reduction, and remdesivir has shown 87% relative reduction. We'll come to that study, and greater than the efficacy reported for molnupiravir. So IDSA has said that in ambulatory patients, with mild to moderate COVID, with high risk for progression of severe disease, it is better to consider starting nirmatrelvir ritonavir rather than not doing it. Of course, the availability of drug is a question at this point of time, but I'm not surprised if it soon enters the Indian markets. Coming to the remdesivir, I'm not going to talk about the mechanism of action. So a lot of evidence for remdesivir. Let us see how to look into the studies, what Dr. Deepak has already told about several studies. This is the first randomized control trial which happened early in the pandemic in China. So here the primary endpoint was, this is by Wang. The primary endpoint was time to clinical improvement within 28 days of randomization, which was not statistically significant. And the mortality was also not statistically significant. But what happened? Although not statistically significant, patient receiving remdesivir had a numerically faster time to clinical improvement, though it was not statistically significant. But there were certain limitations for the study. The trial was stopped early because they stopped enrolling patients because the epidemic in Hubei was brought under significant control. And probably the study was also potentially underpowered to detect any small differences between the groups. And as Dr. Deepak again highlighted about the ACT trial, based on which the remdesivir usage had significantly increased. Let us see how what they clearly looked at and how many such salient important points are there in the study. So the primary endpoint was time to clinical recovery during the 28-day post-enrollment, and the secondary outcome was clinical status at day 15 using the ordinal scale. There are many positive points in this study. The first point was like the median recovery time, 10 days compared to 15 days who received placebo, which was a significant outcome. And the secondary outcome was the odds of improvement in the ordinal scale. Ordinal scale, I'll come to that, which was always higher in all the group at day 15. The rate ratio for recovery was largest among patients with baseline ordinal score of 5. So ordinal score of 5 says that the patient was on minimal oxygen. Ordinal score of 4 says that patient was not on oxygen. Ordinal score of 6 says that patient was on either NIV or HFNC, and 7 said that the patient is either on ECMO or ventilator. So the patient with ordinal score of 5 had significant recovery. And patient who underwent randomization in the first 10 days had good rate ratio for recovery of 1.37. But patients who were randomized more than 10 days after the symptom onset had slightly lower rate ratio of recovery. Mortality was not significantly different, but on subgroup analysis, again, patients at ordinal scale 5 had a little bit of significance in the statistically significant mortality outcome. So these are all the time to recovery according to the subgroup. You can see that everything favored the remdesivir, especially the baseline ordinal score of 5 receiving oxygen had significant benefit. So this study concluded that the remdesivir was superior to placebo in shortening the time to recovery in adults who were hospitalized with COVID-19. So I would say that it was a well-conducted trial, a double-blind randomized trial done just a few months in the middle of the pandemic, which is a tremendous effort. There was the change in the primary outcome received a little bit of attention, but that is how the patients took time, and they did that without looking at the data to date. So that could have been the best possible way to change the primary outcome, and probably their logic makes a bit of sense. And the mortality, when it comes to mortality, again, which got a little bit of attention, the trial was not powered to check the mortality. This is the famous Solidarity trial conducted by WHO. The details Dr. Deepak also quoted. It studied several different other drugs also. So it said no difference in mortality, no difference in initiation of ventilation or time to discharge, but again had a lot of limitations. It was an open label design. it never said about the time of symptom onset to randomization, so which might have created difference to the outcome, because if the if the patient was included later in the after 10 days or so, then the efficacy of the remdesivir is not replicable here. So subgroup analysis were not done other than patients who were already in the ventilated upon the study entry. And there was also a limitation here that the patient care provider could choose to deviate from the protocol. And there were variable number of patients in the remdesivir and interferon treatment groups, and the intention to treat analysis was done in the primary endpoint. Despite patients not necessarily receiving the drug, they were initially randomized to. So when we see these two trials, both the trials had different primary endpoints. So ACT primary endpoint was time to clinical improvement, whereas the Solidarity trial was powered for mortality, but was not designed to examine the subgroups by time to clinical improvement or based on the clinical status other than the ventilated versus non-ventilated patients. So such certain few limitations say that probably we need to understand a little more into the efficacy of remdesivir. This is one more randomized control trial, which the objective was to determine the efficacy of 5 days or 10 days of remdesivir versus the standard care. So on day 11, patients in the 5-day remdesivir group had statistically significant higher odds of a better clinical status rather than the standard care or 10-day treatment group. So this is the discovery trial, which Dr. Deepak also highlighted. There were few limitations. This study again found no evidence of efficacy in the clinical outcome or viral clearance, but we should understand that the remdesivir significantly, in a subset of patients who were not on mechanical ventilation or ECMO at study entry, remdesivir significantly delays progression to mechanical ventilation or death, which was in line with the findings of the ACT-1 trial. And also we should see that the ACT-1 patients were on 87% patients in the ACT study were on oxygen, whereas discovery patients had 99% of the patients in the discovery participants were on oxygen, which says that the disease severity was little severe, and probably remdesivir was initiated little later. Again, though not the strong evidence, there are large-scale observational data on remdesivir outcomes. The remdesivir treatment in hospitalized patients with coronavirus disease, a comparative analysis of in-hospital all-cause mortality in a large multi-center observational cohort. Here, what they did is observational analysis of the large real-world database. Close to 28,855 remdesivir patients with 16,000 and odd propensity-matched non-remdesivir patients. They looked at the outcome. So patients on remdesivir had significantly lower risk of death at day 14 than the patients not on remdesivir. So a mortality difference was also seen on day 28, but of course with a hazard ratio of 0.89. So again, these findings are occurred with the ACTT-1 trial and trends seen in the Solidarity trial. This is again drug treatments for COVID-19, living systematic review and network meta-analysis. Meta-analysis of 4 randomized trials of remdesivir again found uncertain impact of remdesivir on death or progression to mechanical ventilation. However, the study had no subgroup analysis on patients with lesser degrees of illness, and probably might have occluded a benefit in certain subgroup, which we looked through ACT trial. So it also concluded saying that remdesivir probably reduces time to symptom resolution, but whether it has an impact on other patient important outcomes such as mortality remains little uncertain. So the next important study by the Pine Tree group that Deepak also mentioned showed a significant primary efficacy endpoint of composite of COVID-19 related hospital or death from, they looked at the primary efficacy endpoint, which clearly sort of said 87% lower risk of hospitalization or death than the placebo. So this is another important option for outpatients in COVID-19. probably matches the efficacy of the efficacy of 3-day course of remdesivir for non-hospitalized patient with COVID-19 is qualitatively similar to a single dose of neutralizing monoclonal antibody therapies. And of course, yes, they excluded patients who had received SARS-CoV-2 vaccines already. And also the study was done just before the emergence of the Delta variant. So the concerns are still there. So coming to the guidelines, because of the mixed results, there is definitely a lack of consensus among the society and organizational guidelines on whether remdesivir should be used in the management of COVID-19 given the varying results in existing clinical data. However, IDSA as of now says with severe disease, that is saturation less than 94%, IDSA panel suggests remdesivir over no antiviral treatment, and on invasive ventilation and ECMO, IDSA suggests against the medication. On supplemental oxygen, but not on mechanical ventilation or ECMO, the treatment with 5 days of remdesivir rather than 10 days. And patients admitted to the hospital without the need for supplemental oxygen recommends against the usage of remdesivir. And IDSA, again, the Deepak also quoted the ambulatory patients. Among the ambulatory patients with mild to moderate disease, the same IDSA again suggests remdesivir initiated within 7 days of symptom onset. How we are going to administer on a non-hospitalized setting is a challenge. And based on the solidarity trial, the WHO guideline has clearly said conditional recommendation against remdesivir at this point of time. NIH has come up with a little bit of a different triage approach in a non-hospitalized patients. So the panel favors the use of ritonavir boosted nirmatrelvir in most high-risk patients. The recommendation is A2A. Dr. Deepak has clearly explained what is A2A. And if the Paxlovid is not available or cannot be used because of the drug interactions, then panel recommends using sotrovimab, that is a monoclonal antibody. If sotrovimab is not available, then probably use remdesivir, and molnupiravir should only be considered when the other 3 options are either not available or cannot be used. C2A, evidence is C2A. And this is, again, Dr. Deepak has already highlighted for the hospitalized patient what the NIH has recommended. Again, hospitalized but does not require supplemental oxygen recommends against the use of remdesivir, whereas hospitalized requiring supplemental oxygen, NIH again recommends remdesivir along with steroids, and hospitalized and require high oxygen through high flow device again against the remdesivir. So this is a new article which got published recently, very recently, where the Omicron variant has mutations, where there is a threat about the Omicron being having so many mutations in both RNA-dependent RNA polymerase and the main protease of SARS-CoV-2 virus. All these while, whether it is remdesivir, molnupiravir, or the Paxlovid, all the in vitro studies have shown the efficacy against all the other variants, but Omicron having so many mutations, there was definitely a concern regarding the decreased effectiveness of these drugs. But initial in vitro study has...
Sincere apologies, Dr. Venkatesh. Would you be able to wrap it up in next couple of minutes?
Last. This is the last.
Sorry.
Last 2 slides. The susceptibilities of Omicron. The in vitro study says that all the 3 agents work against Omicron, whereas the available monoclonal antibodies may not work against the Omicron variant except sotrovimab. So why do we need antivirals? One is considerable impact on the patients and on healthcare system. So potentially reduce the community transmission and thereby reduce the COVID-19 related hospitalization, thereby reduces the burdens on the system. And if it is monoclonal antibody, requires administration and hospitalization in the ICU in the hospital setting. And now that several countries lack monoclonal antibodies, and even US has shortage of monoclonal antibodies where it is manufactured. So probably oral agents are more practical and patient friendly for non-hospitalized persons, and probably they are going to add a new treatment armamentarium at this point of time. But however, a judicious use of these drugs is important, and so that can happen by appropriate patient triage and choosing the appropriate medication. Thank you.
Thank you, Dr. Venkatesh. In fact, I would compliment all the speakers. The presentations were excellent. There were good reviews on the chat box that I could see. An extensive depth of the search for literature, and a wonderful evidence in support of your deliberations. And just quick couple of minutes to Dr. Deepak for rebuttal. If you want to strongly contest any points mentioned by Dr. Venkatesh. I can't hear you, Dr. Deepak. Sorry.
Sorry for that. I was in mute. I'm happy that Dr. Venkatesh agrees that most of the trials are of low evidence. And the one thing which I would like to contradict is the Act 1 trial, which Dr. Venkatesh said is a well-controlled trial. Actually, I had the slide, but lack of time, I'm not presenting it. The Act 1 trial had a lot of limitations, and it is far from perfect. Like it was stopped early, and which resulted in people originally in the placebo receiving remdesivir, and the matched placebo was unavailable, resulting in unblinding. And not everyone in the study group had completed the full 29 days of therapy when the results were published. That itself might have caused bias. And there is a lot of missing data with the Act 1 trial, like the baseline labs, vitals. And so evidence-wise, strength-wise, it is a very poor study. And the second thing which I want to stress is that now the most common variant is the Omicron, which is declared as the variant of concern by the WHO. And as Dr. Venkatesh pointed out, there are genetic mutations acting which causes interfere with the RNA, this RDRP and all, which and we do not know how it is in, like the action of antivirals is in vivo. In vitro, there are some studies which says that antivirals may be effective, but there are no conclusive, or I have not come across any study of antivirals in Omicron. And currently Omicron is accounts for more than 90% of the outbreak. So I don't think antiviral has any role in the present outbreak.
Coming to the Act 1 trial, if probably we were in the early pandemic where there was much need for the drug. So I also do not know why they stopped the study so early. And probably if they had continued the study, probably the results would have been much more stronger. But that way of looking is also possible. And coming to the Omicron, the recent one of the in vitro study says that in spite of the Omicron having a lot of mutations in the both RNA-dependent RNA polymerase and as well as the protease, the important protease, the in vitro study says that all the three drugs, the remdesivir, molnupiravir, and the nirmatrelvir, are going to be effective. But this is in vitro study, and we have to probably wait for the in vivo studies further.
Thank you, Dr. Venkatesh. Before we conclude, any comments from any of the panelists, from the people who are listening, from the participants? Any comments or anything that they want to say? Basically, please say, or please mention it in the chat box so that we can mention it.
Is there a dose response evidence by using these antivirals in the first week, and we reduce the viral load or abolish the viral load? Will that stop host response is the question. As it sounds, that doesn't seem to be the case based on the available literature, but I would like to hear from the panelists as well as the speakers, if antivirals reducing the viral load, will it actually reduce the host response pattern?
Coming to your question, Dr. Justin, can I answer that question?
Yeah, you should. Yes.
See, the molnupiravir, they have studied between 200, 400, and 800. That is in the first phase of a study that has clearly showed that with 800 mg of twice a day for 5 days had significant faster reduction in the viral count as well as even the infectious virus. I'm surprised to even understand that because the remdesivir has failed to show the similar replicability. But another question, what you asked, whether the host response reduces, that was one of the novel endpoint they looked at in EPIC SR study, which failed to show that the patient did not have, they did not meet the 4 days of no symptom period. So that was not met. Probably the viral load may come down, but the host response probably is suppressed, but rather it might not be completely stopped.
So maybe the antiviral agents are initiated because the incubation period is also happening some 2 to 5 days. So there is a delay in initiation, isn't it? Because once the symptoms develop, there is already some significant replication must have happened. So probably that could be another reason. The viral drugs are not going to be that effective, conclusively effective.
That could be one of the reasons. And also the morbidity and mortality, as we discussed, is mainly dependent on the immune response.
Sure. Dr. Satyajit, he wants to comment as well, please.
If I may take just a minute or so. I guess just standing back without going into the specifics of antiviral agents. One, obviously, the timeline, the general practice, the ambulatory patient versus the hospitalized versus ICU, which you both the panelists highlighted. But physiologically, these drugs are likely to be effective more in the earlier stages, which is true as well. Now, I just wanted to highlight a couple of other dilemmas we face in intensive care or in hospitals and the healthcare systems in general. Both in US and in India, we work under a very heavily privatized healthcare system, whereas Abhinav and myself working in social democracies in the West with the publicly funded health system, where the cost and there is a little bit more significant control and regulation put into these drugs being fast-tracked into clinical practice, which was quite evident in Australia, even though we didn't have much number of cases compared to both US and India. So we have a national stockpile and we have a very strict regulation in which patient groups this can be tried, not mandatorily used. So that's one. Secondly, we live in a society all over the world. We are dependent on the mercy of drug companies for drug development for the last many decades. And we are at the mercy of their profit-motivated manipulations as well. And while we have all benefited from various drug development, and in this particular instance, we should commend them as well for fast-tracking a lot of vaccines to and various drugs. But it also comes, we need to highlight that many of this came about because the governments, both US and European Union and others, significantly contributed with a large sums of money for the drug development, for which they probably didn't get as much return. And the interesting thing highlighted about Gilead as well as Pfizer's more aggressive profit motivated tactics have been noted, and which does give all of us a bad name, as in modern medicine, particularly in Indian context, where there is some a conflict or a tension between the traditional medicine and modern medicine. And then in other thing to remember is a lot of this studies have been fast-tracked in the pandemic setting. Likewise, we are also clutching at straws. So that's there, but that said, it is not unreasonable though to try if companies are coming up with new drugs and particularly antiviral drugs. Obviously, why not? We use antibiotics in septic shock, and why would we use antivirals? But that said, we always have to use a bit of caution with viruses and antivirals, as with our prior experience with SARS and MERS and H1N1 and various things. Supportive therapy, as we know in intensive care, is as important, and the overall management is important. So obviously, any drugs should not be at the cost of compromising that, because we were watching from far while the second wave was unfurling in India, and people were desperately running after high-cost medications, which were probably less important than early recognition and some supportive care and the social support and various other things. So I guess, just to put it in perspective, sepsis have been, and in intensive care and in hospitalized patients, sepsis and septic shock and severe sepsis have been studied for decades. We did not come up with a magic bullet for many decades. Obviously, antivirals are slightly different, but then I guess we're all interested in other drugs as well, and some transfer of or translation of a last decade or so's knowledge gained in immune therapy and other things seems to have been fast-tracked as well. Even though that's not today's topic, that has also been translated into acute medicine in the last year or two, which is interesting. That might be of immense benefit, or that might be questioned in a year or two down the track. So I just wanted to put out a general perspective on these things. Thanks very much for excellent work by both panelists.
Thanks, Satish. I think it is a point well made, basically, because of the scenario most of the people work in, and if you're working in a like NHS and also Australia as well, and where you have to use the drugs that are provided to you, the choices are limited because there are some guidelines made, irrespective of what the evidence shows. Sometimes, unfortunately, remdesivir, the evidence was limited. The Solidarity came out that it does not have much evidence for recovery, but we had to use it because the NICE guidelines. In the UK we followed NICE guidelines, and the NICE guidelines say that okay, there is some evidence that it improves outcome, and so we are using it actually. So the voices are there that okay, it doesn't help, but we are using it because it is a part of our armamentarium as mentioned, and vis-a-vis in a private setup where you generally go by your intuition and your routine practice, and you may argue that the evidence is for it or is against it. I think it's a very difficult thing, but the world has never seen so many trials and so many drugs going on in the because of lack of time. The trials were happening rapidly, and sometimes my teams, we sometimes compare it to as an octopus, where we are using you are studying so many drugs at the same amount of time. And it is very interesting for any student who in the future stage who wants to go through these trials where there's a deviation from the standard way that we conduct trials, and the speed with which the trials were conducted, and the variation in the statistics that were done. We moved over to Bayesian statistics rather than conventional statistics that we used to do, and we came out with rapid results. I'm sure in years to come, all these results will be challenged, and we would see very soon that okay, nowadays we are using this one, and this would be challenged that there was no real benefit, no mortality benefit from most of the things that we're doing. But and the situation will keep on challenging, and will be challenged and will keep on changing as well in the future. But at the moment where we stand, very difficult to answer this question whether the antiviral drugs will be useful, they are useful, or they're not useful. I think it's anybody's guess at the moment. You can argue yes, you can argue no, but definitely I think both the speakers, they had excellent. I would say all the speakers, they had excellent presentations, tremendous amount of evidence, and you really worked hard for that basically. And I think from my perspective, I think it was I enjoyed the sessions. Thank you. And if there's anything that needs to be added, Dr. Ajit, I would congratulate the speakers and and nothing much from me to add basically, because all these topics are highly controversial topics. There's no right answer or wrong answer to that basically, in summary.
So I agree with Dr. Abhinav Gupta. Pradeep, Dr. Pradeep, you want to add anything?
Yeah, thanks, Abhinav. I think it was great to have Abhinav Satyajit to moderate this excellent session. I thought it was a very high voltage sessions. Both sessions were heavily deliberated with a lot of evidence. I mean, it was a delight to see so much of evidence pouring in. And it would have been a great session for all the trainees. And I see some of the trainees have faded away towards the end, but it was a really great deliberation. So my final question, as a nail on the coffin, I should ask if Amarja is there or Ranajit is there, and to Deepak Vijayan. So have you not used antivirals, Deepak, in your practice in the thick of pandemic? I know we have debated, but when it comes to realistic sort of a practice, so Deepak, you would, what has been your practice, Deepak? Have you used it or not in your practice?
No, I agree that I have used antivirals, and probably I think most of them were unindicated. I confess that most of it were unindicated.
Okay. So I think there goes the thing. And Ranajit, how about you and Amarja? What about colloids? Are you still using colloids, Ranajit, right now?
I still use colloids.
Okay.
I still use colloids for initial resuscitation, less than 20 ml per kg body weight. I still use colloids. In fact, I took the debate only for that reason, because I was convinced that colloids can be used.
So walk the talk.
That is the reason I told that I'll talk in favor of colloids. I think most of the people will shy away from talking in favor of colloids.
Great. So Ranajit has really walked the talk. So, so verdict is still not out with colloids. I think with antivirals, it's, as Abhinav rightly said, it's anybody's guess. So I think we can close the session, Ajit, with your closing remarks. Excellent work. And thanks, panelists. Thanks, Satyajit and Abhinav, for great moderation. So
yes. So we would like to thank all the attendees for patiently listening from the beginning to the end. I think few of them have faded away. And we would like to thank the moderators, Dr. Satyajit and Dr. Abhinav Gupta, for sharing their valuable time with us, and all the excellent speakers. We are very much thankful for the excellent presentation by Dr. Amarja, Dr. Ranajit, Dr. Venkatesh Gupta, Dr. Deepak Vijayan. And I would like to thank Microlabs for their supporting almost all of our Procon debates. And finally, my thanks goes to Hallmark Events for organizing the entire event. Thank you all. Thank you very much.
Thank you.
Thank you.
Thank you all.
Thank you.
Thank you, Deepak. Thank you.
Thank you.
Bye, Abhinav.